I would invite also the next panelist. So Dr. Varun Gupta, Dr. Rachna Kucheria, Shalini Bansal, and Ms. Swarnima Bhattacharya. I would like you all to introduce yourself. I can run those slides, but it would be nice to look at the face. नहीं तो वो slide आता है screen पे while the introductions are being made. So Rachna, will you start and you will run the show?
Varun, I think you volunteered, but we can all pitch in. I'm sure. This is working, I assume. Okay. So I am going to refer to my notes, I think, even for my introduction. So I will state at the outset that I am a learner here. I had the privilege of, as I'm sure many of you attending some of the sessions yesterday, and I was astounded with how much more there is to humanizing medicine and dealing with patient communication. So I'm just an avid learner and taking it all in. My formal training is as a physician, Maulana Azad here in Delhi, and then public health at All India Institute, community medicine. And then I went overseas to the US and trained as a family physician at USC, did a master's in public health and epidemiology, and just was fond of, I think, being a nerd lifelong, went ahead and did a fellowship in healthcare leadership. I moved back to India mid-career, so struggled with the challenges that I think anybody would face in trying to, align two systems, being trained one place, doing things that you do there, and the two are very, very different. And then trying to find a fit for yourself, where at that time, people really didn't know what GPs did. The whole scene sort of had moved into corporate healthcare, and people were very happy to go to their cardiologist or their orthopedic, or if the nerve, or as they thought, a calf hurt, let's go to the neurologist. And so when I would say, they'd say, what's your specialty? And I'd say family medicine. They would look at me and say, what is that? What do you do? And that was about 13 years ago. Throughout my career, I'll keep it brief, I've sort of straddled and struggled myself with giving one-on-one patient care, but then never really being satisfied with that. I've always wanted also to help in my way, sort of larger groups of people, so straddle that. Focusing both on systems and processes to make life, I would say, smoother, easier, and more comfortable, both for the patient and the doctor. And in this quest, then I worked for many years with the big, large hospital systems like Apollo, Max, and then a stint with Medanta, where I was working with actually a tech startup at the time, and that's how I met Dr. Beena and many of the others here. And then finally, I've sort of come to my resting place. Hopefully, this is the resting place, as I started my own telemedicine platform about 18 months ago when the government of India cleared the guidelines here. So in brief, I am a GP, a family physician, a telemed doctor, somebody who runs a telemed platform, passionate about public health, is trying to deliver the best I can, both in terms of individual care, training, teaching, all through telemedicine. And I also continue to, for fun and just for maybe a little bit of growth, go back to the US and do some stints there in locum care, where they let me work in urgent cares and other things and keep up skills that are always fun to go stitch a little bit, etc. So here I am, and very glad to be with all of you today.
So of course, I am slightly different from everyone here. I don't come from the medical fraternity at all. I come from the design background, and I've worked across various domains of design, spent a large part of my career in communication. In the last 5 years, I've been a co-founder of a startup where we work on the cusp of culture and technology, where we're trying to sort of digitize heritage and culture and bring it across, make it more democratic. So I think more will come as we discuss.
I'm Dr. Varun. I am a pharmacologist by training, working with a startup 1mg for last 7 years, part of the founding team, helping the aim was to make how you can use technology to make healthcare more accessible, affordable, understandable. And that's where we started off. So doing multiple experiments in different patient journeys. Pleasure to be part of this panel, add to the discussion.
Hello, everyone. My name is Swarnima. And like Shalini, I also don't belong to the medical fraternity. My background lies in public health. I have been working with the multilateral organizations like the United Nations and WHO for the past decade. And I've been very passionate about the intersection of course, technology, health, and mainly gender. That how healthcare delivery has to be more gendered, more self-consciously gendered in its approach. I worked with, in the last 5 years, I've done a lot of work using data and artificial intelligence to improve last mile outreach for last mile delivery of medical help. And recently, I co-founded Thea, which is a female health platform. And the idea behind that is basically to do this, to really identify the pain points along the healthcare system that are very gendered in nature and how to solve for that. I was associated with AstraZeneca as a young health scholar. And the idea behind that was to increase South Asian representation in medical research. As we go along, like Dr. Rachna said, I'm here more as a learner and to see really what, because I believe that, both doctors and patients are working within a framework which has its constraints, and how can we collaboratively find a way forward for basically improving healthcare outcomes. So yeah, so glad to learn from everyone here.
So I'll volunteer to moderate the session. So I think I take the clue from the last session, and it was a very, very valid point that when the gentleman said that the nurse was overburdened by documentation, and he as a patient was expecting her to be more involved in the care part of it rather than the documentation part of it. So I think that's a good starting point for this session, using that as a clue. So I'll just lay out broadly what technology, generally when we say technology, whether it's an enabler or disruptor for humanizing medicine, just to make it more sharp, to just make this discussion, technology is a very broad term, right? And we are limiting at this point, not going to hardware or the vaccines or those technologies part of it. We are going to the softer part of the technologies. It's commonly called as digital technologies, which we call it, right? So, and just as I have understood from a medical background, the things technology can do, there are 3-4 buckets in which you can divide technology into. One is the automation part of it, where there is a path which is clear. Path A to path B is clear. You just document, list down to the finer details, automate that part. That's automation. And automation can be real time, like Google Maps. It can learn by itself. So there can be complexity, nuanced automation part of it. So the documentation part, then generally we see CoWIN, EMRs, all these are automation part of the process. That's one piece. Second piece is, I think, is the decision making. When the path from A to B is fuzzy, right? You can have the data points, but somebody has to take that decision, that which path to take, path A to path B. That's where the deeper parts of technologies come and play the role. Machine learning, artificial intelligence, all those things which kind of mimic the process of a brain and try to take as accurate decision as possible. That's the second bucket in which I say technology lies. Third bucket is the blockchain and digital therapeutics. These are the newer parts which are coming up, right? So some of them, they are all overlapping kind of things, but these are the third, fourth piece. And fourth piece, I think, is which is the most core to a human-to-human interaction, is the emotional part of it. How do you respond to another human, right? And I think technology is still very, very far away from simulating that part of the human-to-human interaction. That's very, very far away. And that's what I'm just laying out the context. I think in the entire piece of a patient-doctor communication, starting from, I heard you saying that journey starts beginning from the symptom to beyond the clinic, right? So that piece, automation can play a lot of role. Decision making is specific use cases. We have to decide whether technology can take decisions or can help doctors take decisions. But clearly, there's one value which technology is not adding, that is the emotional, or how do you respond to another human? How do you communicate those decisions in a more sensitive manner, right? So that's where I think that is where technology should take over role of documentation assistant, all those things technology should take over, so that that frees up the time of the doctor from doing a lot of things which can be done by some assistant, right? So task shifting, as we say, that should not be done. And that's where I think that's the fundamental point. I think future of we have PMTs and NIT exams where we look at the IQ of a person to get into a medical school. Why can't we change that? Why can't we just have more assess person on an emotional component? How is reacting to another human? If that is the process of including people in the medical school, that can, because in future I think the differentiator would not be that how much analytical skills you have. Just taking a simple example, if I was a specialist in maps or geography, right? Howsoever good would be, but Google Maps has democratized the world, right? So it has democratized. My analytical skills, my specialization would not matter at all. That is democratized. Is that how do I take decisions based on those data points, or how do you communicate those decisions? So that's what I think is that's what my view. And I think that's I would open up to you to say that what's your take on this. So
No, so I think this is, of course, very valid. When we talk about humanizing medicine, there are two aspects to it, I feel. One is, of course, what Dr. Varun laid out with great detail, the emotional aspect of it, which is obviously extremely important. Another aspect of it is humanizing, like really defining what we mean as the human form in medicine. Many a time what we see is that, now there's new research that says that every cell in our body has a sex. But when we are talking about medical treatment, when we're talking about diagnoses, then it is the male body that is seen as the default, whether it's pain medication, whether it's cardiovascular disease, mental health, etc. Whereas the implications are totally different. They're very gendered in nature. So this is another aspect of humanization that we have to very critically take into account. There is more research now that says that in countries like the US and other places in the world, people of color, have a different response to medication. People of color have different healthcare outcomes, and there was a lot of data that was generated even during COVID. So when we are talking about the human subject in medicine, along with humanizing them, there is also the need to, look at what our default has been so far, and that has really affected healthcare outcomes in empirical terms. So I think that is one starting point, and I would love to, of course, learn from your experience, about how.
Yeah. Indian healthcare system like Ayurveda, Ayush, actually believe in personalized medicine. So, but as modern medicine physicians, we debunk Ayurveda out of hand immediately. But Ayurveda was all about individualized, personalized, to you treatment. What do you feel when you are talking about humanizing and individualizing treatment? How do you feel that fits in with what you think?
So this is a very interesting question in terms of personalization versus protocol-based care. As somebody who's working in female health and not as a medical professional, I have seen the pros and cons of both. There is a degree of personalization and, the personalized to you thing that's extremely critical, because we see that, when it comes to women's health, especially, there are so many other things, like there's hormonal health, there's mental health, there are so many other stressors and factors that affect your healthcare outcomes. So the degree of personalization is critical. But at the same time, I feel, and this is something the doctors can answer much better than me, I also feel that one of the things that things like mental health, adolescent health, female health, or geriatric care is suffering from is lack of standardized protocols. When you, for example, a woman with PCOS, when she goes to, so I'm from Lucknow, and, so when I go to a gynecologist there, like at an average case, it's not a generalization, but, if you go to an average doctor in different parts of the country, they will have different responses to something like PCOS. There is no standardization, but there should be. Of course, the care has to be, the care and the treatment, the long-term care has to be personalized according to the pace and priority of the patient. But
But very confusing to say.
So can I
It's very
jump-
dichotomous.
Yeah. So I'm going to jump in here, and some of this was also spoken about in a previous session about there being imperfections. I thought the doctor here, I think Dr. Prabhat, it was imperfections both with physicians, the patient, and medicine itself. And I think communication here is a key. You're absolutely right, and PCOS is a great example. There are various options to treat or not to treat. And I'm going to sort of take a little segue and connect a few dots here, please bear with me, both as a family physician, a GP. So you become sort of the holder and the first point of contact for the patient. Also somebody then, by virtue of what you do, a lot of the geriatric patients come to. I'm also the doctor who delivers care at home. I take my bag and go. But as a telehealth doctor as well, I think one key message, and I really like this line when you talk about emotional health, fabulous construction of what digital healthcare can do. But I would also add that for emotional care, and we talked about COVID and ICUs, the one thing that connected families was the iPads, the phones that were available. And this was made available in US. They had bedside tablets, which prior was only being used for entertainment, but you could connect families that way. I myself personally had a father-in-law who was almost 90, who had to be sent in the height of the pandemic to a hospital for dropped oxygen. And that's what kept him going. All four of us, and we have children and people all over the world, different time zones, he was connected to them. Kept him in good cheer, and thankfully he was back home. Your patient, Dr. Veena. So I think that telehealth brings, I would say, the doctor back to the patient's home. We had taken this away. It is more leveling. You come to an OPD, and again, there's a space for all of it. I'm not saying it's here to replace in-person medicine. I myself do many versions of it still. There's the hospital, there's the outpatient space, maybe the patient space, but this is the third space of medicine. It's here to stay. I'm fully convinced. It has its place. It needs to be judicially used. Patients' voices need to be heard, but I think it has a great space for many of the things we've touched upon in previous sessions as well. Emotional connect being one of them, and also being a great leveler. What is happening in OPDs now? I don't know if they've changed in the past 2-3 months, but over the past year, we had to protect ourselves. There were plastic shields around doctors. If you thought that there was distance between patient and doctor, see it now after COVID. They've been reconstructed, masks and all of that. This is for outpatient, where really it is a lot of what you speak is going to convince and change patient behavior. It's going to take you, as I tell the patient, it's taking me 30 seconds to write a medicine. But if I'm talking to you for this long, then that's what's going to really make a difference. But that's now gone down. Telehealth takes that away. They can see my face, actually. They can see my compassion if I have it, or irritability if I have it. So both need to be taken care of. And I can peek into the patient's home. I can see how they're sitting up. There's so much other information that you can collect. I would say I'm a telehealth learning doctor. We were never taught this. We just like laparoscopic surgeons were never taught that in med school. They were opening up abdomens. Then they went to laparoscopy through a keyhole. Now they're on to robotic. So it's a lifelong learning. I'm also learning. So you can get a lot of information about the patient, the family, who's caring for them, how the home looks. And the patient also gets a lot of comfort. With that, I'll let somebody else jump in.
They are so much more comfortable when they are speaking from their homes.
Yes.
Sitting on their dining tables or whatever. I agree completely. And you can start the conversation with the background.
People talking about how their back hurts and neck hurts. And I want to see the chair, not the workspace. You see the chair and you get a fair idea of how they're sitting over there. What is the chair constructed like and how it works on their back. And it's so,
and the saying that the home speaks about you, the photographs
actually-
behind, the paintings behind, you kind of.
So what you're referring to is actually, what we really work with when we begin a design process. This is ethnographic research, actually, to be able to place a problem, if I may call it a problem, in its context, and to really get down to studying the problem where it is, to meet the person where the person is. And that is actually what gives you a lot of data, which then perhaps can be analyzed and can get into a lot of other brainstorming and information synthesis. So like you rightly said, telemedicine certainly, of course, other than the other benefits that it is providing, this is something that it really does. Also, to what you said, a lot of work has been happening based on guesses, based on perhaps what one felt was good, or based on what preferably machines could do or the system could make happen. Um, Now, I think the process is slightly changed, and what we're wanting to discuss here through these last 2 days is that this whole thought process has to change and the user has to be at the center. So the technology has to work as per the user, whether the user is a doctor, whether the user is a paramedic or the patient, uh, you know, whether we are talking of machines, how does the user react to a machine? Because the machine finally is being used by multiple people. There's a person who administers the test, the person who gets into the machine for the test, and so much. And then, of course, many other elements. We'll perhaps come to them as we discuss.
So I'll just ask and take a clue from this. So from your perspective, from telehealth perspective, what do you think you have mentioned about the pros of it, right? So technology acting as a facilitator between a doctor and the patient. And what could be the kind of the risk of this? What do you think? And do you think that if on the other side of WhatsApp, if there's a bot, do you think that would, if WhatsApp is just enabling a human interaction, that's good enough. But would you like to talk to a bot on the other side of the WhatsApp or Facebook or telehealth platform? I mean, just what's your views on pros and cons of where it is an enabler, where it can be disruptive?
I think I talked about some of the enabling aspects, and what you talked about also the decision support bit. Once you have the EMRs, which is now, as I said, I also work cross continents. I work in the US, and there is no paper anymore. So to me, and our system will also get involved. All of this requires money and resources. When I'm filling out an EMR or filling out even a prescription or a note there, I get alerts. If there's a cross reaction, I get alerts. To build all that, of course, takes time and money. I get decision support, by that very simply for everybody, some may get it, some may not. If you're doing something or you have a patient with a certain critical value or some issue, and there's some research coming in, or it's let's say, this patient has cardiac disease as well as diabetes. Have you looked at, let's say, SGLT2 inhibitors? I know you endocrinologists do it all the time, but remember, we are also family physicians. We treat the toenails and the depression and their cough and the mother-in-law's problems. So sometimes it gets hard for us to keep up with everything. I will be honest and admit. So it's nice to have a little bit of decision support coming in when you're looking at palm, sole, corns, and everything under the sun. So that's the pros, many pros I can say. I think the cons is that if not used properly, and the bot can't take over the clinical interaction, but they can, I agree with you, a lot of the pre-stuff, which will free up the doctor's time. Fill in the medicines, fill in your previous illnesses, your last menstrual period, allergies. This, if you can collect, then the doctor has we take then 15 seconds to scan through that and come to so I think that can be helpful. The caution, like for anywhere you practice medicine, is that do it appropriately. Know your limits. And whenever I onboard any doctor, I say, please feel free to cancel the teleconsult, say you need to go in person and refund the full refund. This is what I reiterate again and again. I said, give them money back, let the patient. So like anywhere else in medicine, do the right thing, do it every time, and just, don't bother about the financials of it. I think if you can be cautious on that.
So all the patients are their own base and there's a continuity of care.
Yes.
So what happens when telemedicine is used in wherein either you call in and today there's one doctor, tomorrow there's another doctor? What happens to continuity of care in that kind of a telemedicine? Which is a lot of it is happening, right? So there's a lot of on-call. You just call in and then there's somebody to help you with the dermatology problem, and then the next. So even at the hospitals, tertiary hospitals where I work, then this has been there. So during overtime, everybody put up tele units.
Okay.
And so the first time the patient calls, it's an X doctor. Next time the patient calls, it's a Y doctor. And though they can see some of the notes, there is really no continuity of care for the patient.
May I ask a question back there? It seems to me this is more sort of a urgent care access, which is also great because then you get somebody as and when you want them.
Yes.
So it's like a virtual urgent care, which is great. But when you want continuity, is that in the patient's hand? In our case, they're able to book with the person they want to book. So if I saw Dr. Beena, I'm going to press the button again and Dr. Beena opens her record. She sees all the past 14 prescriptions and quickly she can scan and say, "Acha, pichli baar ye kaha tha, abhi keh dein." So are you talking about they were giving like immediate access, sort of a virtual urgent
So
care?
maybe it was more of a virtual urgent
Right,
care.
right.
And so are all platforms like yours now
I think they should
in a
have mix.
telemedicine
I think they should
setup?
have a mix. We don't give, our limitation is we don't give immediate access. The closest is 1 hour for the patient. The doctor gets 1 hour notice. Because abhi mujhe to we don't have that. But I think there will be a hybrid and there are already hybrids of that coming up where you have like a virtual immediate access and then you can have an appointment access with your regular doctor.
Just adding to this point,
One question I would like to ask. So when the person takes the appointment with the telemedicine doctor, is it recorded? Is the whole interaction recorded?
So we have it two ways now. We do what's called assisted commerce. We feel that this is the, the middle path between pure technology and pure person to person. Give me a second to, this is actually how Amazon started in India. They they realized they couldn't do their press the button model here. They went to Chota Kirana Walas and you could go there in the early days and you could go there, order whatever fancy product you wanted. He said, "Paise de do," then they would get the thing. So we do assisted commerce. You can have a voice-on-voice interaction with staff who pick up the phone. We also have a bot who's doing appointments for us, to your point, on WhatsApp. The entire interaction right up to making of the appointment can be done by a bot. Does that answer the
No,
question?
what I wanted was, suppose,
Is there a recording?
is there a recording of, suppose you're the patient, I'm the doctor, and I'm asking a history. So is that history being recorded and can it be documented on that electronic medical
Yeah, we don't have
records?
voice to word right now, but I can do this. And of course, I'm giving you my full attention. If I have two devices,
No, the reason being, I have a lot of patients who say, आप computer पे हो तो आप मेरी बात नहीं सुन रहे हो, and I'm trying to tell them that I'm typing out what you're saying. So it's going to take me this. So, usually the point of contact is when I'm looking at them, you look eye to eye, you make a point of contact with them. But when you're typing out, you're looking here and not all the time looking at them. And especially the elderly have a problem. आप लिख लो, फिर हम आगे बात करेंगे.
I would caution.
So
against
that is what
I would caution against that because it's
very interesting point.
Yeah.
And
And I see that many times. So
so I
that takes a 5 minutes extra. It's a 15-minute consultation period. It takes me 5 minutes extra to fill up, but that 5 minutes adds up to my lateness,
that is
which is
exactly
I'm always
what is-
anyway late.
that is exactly what's going to contribute to patient satisfaction. Somebody asked me outside, we were chatting, how do patients get faith in you? First they have to meet you and then they'll get faith. The first timers may not come. I don't think so. Or at least I'm getting a different experience, thankfully. And that's exactly the point that first 5-10 minutes, you have to have the eye contact. You have to give them your full attention. And you may scribble a thing or two here that you want to, whatever. Or sometimes I even prep. If they've been good enough to give me some notes and things pehle, while I have a few minutes, I'm drinking my chai coffee, I have my thing on, I've seen, and they're like, okay, thank you. I know you have diabetes. Why don't we talk about blah or what you're here? So then it's also a little prep. The patient feels, wow, doctor ne ye dekh liya. So
nowadays, sometimes I don't put on my body.
And then I wish instead of that, if it would directly come into my electronic.
So that's where this is. I would say that's a design by design, right? So it's a by design. You can create different levels of interactions, and I mean, when I started working with the design team, I was not aware that that's what is design thinking. I used to spend a lot of time sitting and the person looking at the problem from a different perspective, looking at all these things. Technology, this is possible. All we are talking about is possible. Is what you want to comment on this? That what the point is how this cross-functional looking at a problem makes a lot of sense.
So this is exactly where I also spoke when we were discussing communication. This user journey is really long. It's far beyond what really happens only in the doctor's clinic. and it begins much earlier and ends much later. Perhaps 1MG may be doing this now that you are really invested in making technology design friendly in the whole process. It is about mapping this user journey in great detail. And I think Beena, we also we also did a little bit of this, before we set out the theme perhaps for this this entire conference, where you need to break it down to the last bit. And I'm not talking only from one user here. Every stakeholder is a user, whether it is the patient, it is the caregiver, or it is the paramedic, the staff, or it is the doctor, the surgeon, and there's so many others. There's a chemist as well, and there's so many others. So yes, technology is an enabler. The users are so many, and perhaps and the first discussion, Nandita, where all of you were discussing, there's so much change needed in how we begin this entire process. Actually, what we really need is design thinking in medicine.
That is what we do without understanding that we are doing
Yes.
that. All the
Time you're designing.
as
Every one
Shalini
of
had
us.
once told, the conversations are also designed.
Yeah.
I mean, we are designing.
Aren't we
those.
designing what we're
Mm.
discussing right
Yeah.
now? Each one of us does that. You're designing your conversations, your interaction with your own
Yes.
children all the time at home. And it is the same thing, actually. The only thing is perhaps you've been designing a lot of what you are doing focused on what your interaction with the patient is. And maybe there's so much before and after, which is actually influencing what you're doing in a large way.
They lose out and you lose out on them because the first time it comes, they say this to you, you don't really think about it. The second time, it strikes. The third time, you're really thinking how I can improve. But those 3-4 patients have already
I know.
lost out on this because I have not thought of it. This is the first time I'm coming to it. People rethink this. I
Oh,
don't know
yeah.
if it only happens as you evolve. It can happen.
But as a function, so that can be kind of, researchers can work on those, detail out those use cases, detail out those specific points, journeys, then simulate those journeys in a virtual environment, then go to production and make it live. So, I mean, I think technology, when it is, the work is repetitive. Doctor is taking a lot of history. That repetitive work can be, technology is a big enabler in that sense. Format, right.
One more enabling thing, which I, in my diabetes practice, would want to have someone to design that. And I think, for example, Mayo Clinic has beautiful statin decision aids and decision aids for. So they were talking about shared decision making. The problem is that explaining to the patient each and every drug, what the drug can have, but those designs are there already. You have decision aids, like if you start medicine, this is the course you may have, in a very graphic manner. It is not verbal communication which may always explain the things. We need some verbal infographics, for example, or some online interactive tools. I think doctors need help from decision science and decision aids to help the communication. We are relying so much on just verbal communication and our mood. It shouldn't be so subjective. It should be dependent on so many other things.
If I may jump in here very quickly, and also tying up to what Dr. Varun was saying, these days patients are not just patients. Now with the advent of platforms, patients are users, they are customers, and they're also patients. And the journeys, like you very rightly said, the user journey for everything is so different. Now, when you're talking about designing aids and how to enable the decision making, now the good thing and the bad thing is that there is so much information out there and there is so much decision making happening, and that is why going to the earlier point is that everything is personalized, but the personalization is based on very flimsy medical grounds many a time. Most of the people, and this is maybe you can, Dr. Rachna speak to it a little bit, that, when patients are coming to a doctor, they have already done a very detailed, study of their own, this thing. They will already come to you with a prognosis or something like that. And they will already tell you that, but this didn't work for me, that didn't work for me, but why did you try those things? Is not something that they will have a good answer for. Now there are Instagram health coaches. That's a very formidable block of people that I think medical practitioners Yes, there are health coaches, there are, there are care managers, there are all kinds of, nutrition coaches, it's et cetera, et cetera. These are all formidable um, presences when it comes to caregiving. And there is a reason why people are gravitating towards it. There is a reason for that. And a lot of people do ask us this, that, why, like, are women, gravitating towards wellness? Don't they understand this is not evidence based? And I also subscribe to that, thought process. This is not evidence based. However, many a time people are looking for more than just evidence. Many a time people are looking for, just give me an answer. I'm going from door to door. I'm talking to 10 doctors, and 10 doctors are giving me a different answer or an explanation for my PCOS, or, my endometriosis, or my fibromyalgia, etc., etc. So where do I go? Then in great pain, a person goes to, I don't know, somebody, and they're like, these are, do XYZ things. So, spiritually, you will get a lot of relief. So a person in pain listens to that, or at least tries that out, etc. So what we need to sort of, when we're talking about humanization, I think we have to look at the limitations of medicine, as Dr. Rachna said, but also not just the limitations, what is really possible. It is true that conditions like PCOS, endometriosis, these are chronic conditions, but these are also genetic. This is precisely the problem when people are told that this is just lifestyle. There is a genetic component to it. There are environmental and other components to it. So it's actually a bit erroneous to this is precisely the that when we say ki lifestyle mera kharab hai, there is a like PCOS is as a fat person's or lazy person's problem. It's not exactly that, right? So it's not, not just a lifestyle or not just a reproductive this thing. So this is exactly the thing. So a patient goes to different doctors and they're told different things. Somebody will say, okay, this medicine will help you. Somebody says, nahi, tum apna wazan apna kam kar lo, tum theek ho jaoge, etc., etc. But actually, there is more than enough evidence out there that says that this standard protocol will help you. Beyond this, you can personalize based on where you are in your journey. A 24-year-old woman with a PCOS and a 34-year-old woman with PCOS will have stations of that illness. So the personalization can happen in the long-term care journey, but there are protocols, enough evidence-based protocols that exist where you can start off your patient and say, this is what the evidence says. This is what a multidisciplinary approach will give you. Yes, you need to make lifestyle changes, but this is the limitations of it, etc., etc.
And then on top of that is
Which is important. Yeah, which is important in mental health. I mean, obviously, people are, oh God, I'm so depressed. People say that, right? I mean, but do you have clinical depression, etc., etc.? What are the factors for your mental health, etc.? These can be, but the diagnosis and the treatment, there has to be some level of standardization, and there is enough to go on as of today. I
completely agree. And just to add to this conversation, before this discussion, I was having offline discussion with my mother. The weekend, I was just talking to her. So just trying to explain that what this topic is all about, right? So, and this standardization point came up. She said that we always ask for reference कि आप जब मैं किसी डॉक्टर के पास जा रही हूँ तो reference मिल जाए. मैंने, why do you ask for reference? Is that the comfort or is something else? Because I'll get more attention. The outcome would be the output will be more, right? So, and I asked her a simple question that look at a calculator, right? You put 20 into 56. You put at those calculators 5 different calculators. Everybody would give the similar output, right? We go down to a non-digitized data. That's the output. So I think as the stage of evolution of healthcare and technology cusp, as we are in the ecosystem, I'm just being repetitive, that automation is kind of what COVID has done for vaccination, just providing an access to which doctor, which hospital vaccination is there. That's clearly there. Second stage would be that standardized decision making. Output from the technology systems is more standardized. Right, so that's what
I'm just going to add on and perhaps take us to a slightly related but slightly different point also, which I do want to make at this panel today. And I think at a certain level, most doctors do operate from some guidelines. And I think it's become so spinal now that you forget ki wo kaun sa tha, but it's part of us, just like you never forget how to use chopsticks or ride a cycle. It is spinal. So I think at a level you do, but there are the imperfections. The science is not an exacting science. To that point, I will also say in humanizing medicine, what about superhumanizing doctors? That is also a problem. Sometimes your patient expectations are like, I'm not a superwoman. I really am not. As I'm told by my patients who will carry sometimes 3 kilos worth of files from Doc Saab, from the nephrologist, from Dr. Kaushan Madan, sabki files over years, and then trot in to see me and say, "Kisi ne bola tha ek simple GP ko dikha dete hain." Say simple GP to me, and my hackles will rise. Right, and I will have you also know that, and let's just put it out there for what it's worth. This is also our earning; it's our living. We are the lowest rung paid, right? One, and let's talk about hierarchies in medicine. We are the lowest rung paid. There's a certain hierarchy here also. If I'm to approach a specialist, not so much now, but Dr. Beena, there's a certain deference. Doc, what do you think? Okay, you know the finest, the last points in sugar and thyroid, all of that, I have to still treat it. And I may know 60 other things, but there is a deference. There is a hierarchy there as well. It is not a level playing field. And it is us who the patients will hit up. It is us who go to the patients' homes if we do, for everything, and their relatives, and also want access. And then on top of that, say ki, Doctor Saab, raat ko to aap milte nahi hain. And you're not allowed to, I'm telling you this, help me. Help us also. I'm not superhuman. How can I talk to you at night? Do I not need my 8 hours sleep? How do I survive as a solo physician? Do you want us all to practice in big corporate hospitals? So you park for 3 hours, you pay what they want, the doctors get paid a small fee. Do you not want us to exist? And this is what's happening. So stop superhumanizing us also. We are also human beings. We don't want to burn out. We want to do the right thing. But that is also being just taken away from us.
The specialist will give an opinion, say 10 things, they'll come back and they'll say, अभी आप हमें समझाइए कि इन्होंने क्या बोला. आपने इतने सारे पैसे पे करके 15 मिनट 20 मिनट वहां पे, you took the time, you stood for 2 hours, spent 15 minutes. Why did you not ask the question to that particular doctor?
Which also sometimes I take it as a positive. Ajkal, that's the mindset shift where you said that, the more tolerance. I just keep saying, this is my family member. They are not doing it to irritate me. They are doing it because they genuinely are distressed. This is the mantra that goes in my head. I'm telling you, how do I humanize my own self? This is what I do. I tell myself, this is not about me. It's meditation. Okay, then objectively, look at yourself per se. This is not about you. This is about their pain. They have not come to, ruin your Saturday evening, where they call you on Saturday evening because they had pain for the week, but 9 p.m. on Saturday is when they discovered it.
This is classic. This is classic. Saturday evening classic.
Or is desh mein hai, as I practice, as I said, I practice in both countries, and I love being in India. But I will say, for doctors, life is so much better in the US. There are no phones given out. I switch off my phone or my head on Friday evening at 4 p.m. and I'm great. But patients don't get access to doctors. My friends call me from there. 6 weeks you can't see a primary care. Here, I'm beholden to my phone. I have to run away on a holiday and literally, beg somebody to take the phones for me. Otherwise, I will go stark raving mad. So those are also the things that, humanizing things for doctors are also required. Otherwise, you will lose great people. I have great friends. I won't name him, but he's one of the 5 physicians in the city I can count, a great diagnostician. We will lose him to real estate, to building homes, because he is burnt out. So we're doing this to ourselves, the horde of the superstar doctor, all of that. I think we need to address physician burnout, expectations,
That's what I was
healing ourselves, building strong communities amongst ourselves, sharing brains and minds. And I think telemedicine has a role to play there. If we have a Dr. Beena sitting here, who is the boss in diabetes, why can't somebody in Chhattisgarh, whatever? And there are enough people to help bridge the payment gap also, access her brains, even a junior doctor. Why can't she be talking to 10 other or 50 other doctors and upskilling them? That is the best use of her time, my time, the little I do, I would say. So I think that is the power, rounding it all back to digital healthcare. That is the power of digital healthcare, telehealthcare, that we can extend ourselves much better for those skills that we have, to those who need it most, giving of ourselves, but also trying to earn a living in the meantime.
That's so true. I think I want to interrupt 1 minute over here. We also have to get away from the fear of another doctor poaching your patients, which is a huge thing in, I think, in India than anywhere else in the world. That if you're on holiday, you referred your patient to somebody else, and that doctor is going to poach your patient. We are 1.3 billion people. वो नहीं कोई और आ जाएगा. So I just wanted to add on that. Sorry about this.
No, I actually, completely agree with what Dr. Rachna said. In my many, years, I think one of the things I have done most is like talking to doctors and, like learning their whole journey from the MBBS days to like, they like kya karwate hain. And it is, so which is why I think when we talk about technology, I think this is precisely where technology can help in disrupting the systems that we have around it. It's not so much as, papering over flaws or anything. It's more about streamlining the systems. For example, when it comes to, again, the reason I keep harkening back to female health is because that's all I'm equipped to speak about. And I will not touch the other aspects. When it comes to women's health, for example, we have seen a lot of questions around data, the use of data, personal logging, symptoms, etc., etc. But what we are seeing over the past many years, in India, it hasn't caught on so much. Hopefully, it will now. But outside, period tracking, intelligent, predictive, things, this has taken on in a big way. And this really helps a patient advocate for themselves in healthcare settings. And it gives the doctor much more data to work with, which is personalized and medically sound. So this is precisely where I see the hope of data in disrupting systems or in streamlining systems which are not working that well. I'm not saying it's not working, it is working, but not working that well for either the healthcare providers or the patients. And I think COVID has been a moment of reckoning for a lot of people, doctors, nurses, mental health practitioners. There are people who come to our platform for mental health practitioners saying that my therapist is not well and she needs a 2-month break. Of course, she's going to need a 2-month break. Like, who wouldn't in this, socio-cultural, political, economic climate? So when we talk about humanizing medicine, it's not just for the patient, but really what is the role of medicine and how are we giving care to one another? And I think, Dr. Varun is, I think, most equipped to speak about it, but data is really streamlining those processes. Those things that we often don't see, those things that, often don't, which we're learning about ourselves as, in terms of our health, our lifestyle, our vitals, etc., and more specific granular data about our menstrual health, mental health, etc., how that ties up to our gut health. There are just some brilliant products out there, and that, in our opinion, in our limited observation, is improving the doctor-patient conversation. Like, it's happening at a different level with the use of personal data, and I think Dr. Varun is, I think, most equipped to speak about the use of data.
Can I just add a point here? So since March 2020, when the lockdown started, I've been working online. And I've been a physician in that locality for many years. And when I moved to online, I did not know how to go about it. I'm a dinosaur when it comes to technology. But it was just WhatsApp and a stand to put my phone. And I just got one assistant who started booking appointments and sending messages. But it took me maybe 2 to 3 months to streamline that whole thing. And I'm still working online. And it has reached a point where I get data before I start my OPD. So I actually make my notes. I'm still a paper pen person. I make my notes and when I'm starting a call, I already have seen the last reports and the previous reports and my previous prescription, what I said last time, because I write a lot on my prescription. So, and they have met Dr. Joita once and they've met Dr. Beena. What did she say? Everything I've known, and I know the tone of that. With that data, I'm sure if it is easily available on a touch of a click of a button, then I don't need to go through all of that. But when I'm talking to the patient, there's no bot there, there's no AI. It's my eyes and the patient, and it's just we are talking to two individuals talking as it was. And once the call is over, again I'll go back to my prescription and sending it. So we can merge technology and the human part, and I'm sure we can make the best of.
But I think the conversations very, very interesting, very amazing conversation. Sometimes I think our models, healthcare delivery models, have been built physical first, right? And we are kind of incrementally adding a lot of layers over this. Sometimes I'm just thinking aloud at this point that digital first is what we maybe that's what we have to maybe think through. Build it digital first. I was talking to Dr. Saab that suppose there is a hospital. If they're adding more units, what will happen is that they will incrementally add. They will have to find a space to incrementally add, right? So simple phone example like mobile phone. Nobody thought that mobile phone would have GPS on all those things we do today, right? So if you incrementally add those things, that might not be the right approach. Maybe we have to build it from scratch and think that we are in the new world. This is the new world. Just whatever is the service delivery model at this point, good. Let's maybe build up grounds up technology first, think how it can be enabled, because all these challenges are real challenges, right? So these are all complexities which are involved, and I don't think incrementally adding that makes economic. Forget about sustainability. How do you get sustainability out of it? But that's a different aspect.
I have a small point here, organic. I don't know if you have time, I'll take 2 minutes. I like the non-digital part to stay somewhere in medicine always. I would love to have somebody doing the prescription and data and everything, but I still want that small element, which is why I'm doing medicine.
Which is the most vital, do you think? Out of that most vital, what is the most vital you want to keep it? If you have to give up a lot of things, what all things you would want to give up, and what is the thing you would want to keep with yourself?
When I'm talking to the patient, if I can touch the person, if I can look into the patient's eyes and I can see that the tear is not coming out, but there's a twitching going on. I can see that the person is talking about the child's PCOS, but actually the mother is worried about so many other things. If I can continue that human understanding, which is beyond words and data and everything else, that is something which is the core why I am practicing. That is what makes me start my OPD every day. And when I end my OPD, that's what stays with me, not the number of patients I've seen, but that mother who said that when you talk to my doctor the other day, she actually understood that point. Or when a elderly senior citizen says that I like talking to you, although we are the same medicine, the same prescription is written again, but I still like when I speak to you about what's going on. I think that is what keeps me working.
How technology actually can enable humanization rather than disrupting it. It's just that how do we do it well? I think it comes to that, and how design thinking can help in that. Telemedicine, of course, has grown leaps and bounds over last few years. And Swarnima, your app, we are awaiting.
Yeah.
I think recently there was an article on Apple getting
Yes.
app of the year. It's so similar to what.
It is for 8th March, Women's Day, when we are announcing. We are a bit
Also,
corny that way.
their photo,
Yeah,
their
so-
pictures are all over the
Yes, so
place.
we are like live, but we thought that, let's be a little corny and let's do it on Women's Day. Just like a female health app. So,
Oh, same day हो रहा है.
yeah. So
You have a strong competitor there.
that's okay. There should be. I think, the thing is that, in the sadness, the thing is that the female health market is only going to grow, and that's good for us, because that is how we're going to learn what are the kind of models that are going to work and not work. There is, like you were saying, the online offline. We believe our hypothesis could be completely wrong, but currently we believe that it is a hybrid model that will work. There has to be data, it has to be data enabled, but at the same time, it is impossible to take away the necessity to visit your doctor in person. So how might we streamline that? How might we do that journey? That is something that's a long-term vision. Like, we don't think that setting up another hospital is the solution, but how do we really streamline those smaller practices that exist and are creating a lot of value? How might we do that using data, etc., etc.? So the female health market in India is poised to just erupt. it is a $1 billion market, and even $1 million of it has not been captured. So there will be many who will come, many will perhaps not stay. So currently our aim is to first stay, is to build to stay, and as we stay, we will learn and we will keep building. That's, I think, our
All the best for that, and all the best to all of you for helping us out communicate better with the patients. With that, I think we end the whole meeting to on humanizing medicine, and all of this is captured, of course, digitally, and I am hoping quickly on the YouTube channel and on my website, and on the website on humanizing medicine.
yeah. Hope we have edits also.
So you will have to speak to the technology people there. I am not as technology friendly as I would like to be, but I think something good will turn out. How I have explained to them that all this, they said it will take time to process. I said, no, this is like books dete hai na. So this is our video book. It has to be available because people would want to go back and refer then and there. This is the time they want to go back and check that presentation, because there is so much of overlap between the discussions today and what happened yesterday. I was just comparing, and if you go back, you'll see that there was a beautiful thing on hidden curriculum in medical training, and it was amazing. So how so many points intersect. I think
That point, if I may add, there was an initiative actually by the government of India about 4 years back.
There was I would say it was an effort by the government of India about 4 years back, where they actually did appreciate that design thinking is required in the medical curriculum as well as in the engineering curriculum. However, of course, perhaps the whole discussion fizzled out because of COVID.
hoping that we'll come out with some white paper or something.
Yeah.
Maybe each of us can write a small
what you can
bit.
do as an outcome of this entire conference is actually work in tandem with some institutions. So IIIT Delhi, for example, I'm aware because I go there as a jury expert once in a while to sit on design juries. They did an amazing project with Delhi Mohalla clinics, where again, some of us have spoken also yesterday. The doctor from Allahabad, Dr. Bajaj, mentioned about the challenges in community health here. There's some outstanding work happening out there, and it's being done at a real grassroots level, where design thinkers and design practitioners are involved in really analyzing what the problem is to begin with, identify the problem, and then of course the solutions have to come, of course, from the community that works on the whole thing. It cannot come from
Public health is an area. And morning there was another speaker who is in public health sector, and he said that, for example, there are simple things. Asha workers are being handed some recorded thing, and they go and play that in the regional language, so that the message transferred each time is same. Simple things.
Very simple. Just that you should get the tool to the correct people at the correct time, perhaps. And treating them is not so difficult all the time. It's just about. So I think there is a lot of initiatives that can start with work.
Thank you. Thank you. Thank you all the